Thank you. Hello, everybody. Good evening, good morning, good afternoon for everybody. Welcome to this very important session, the panel discussion session. And in this panel discussion session, we are going to have three outstanding leaders in the field of assisted reproductive technology. And also, we are going to have the co-moderator with me, Professor Mohamed Abo, another leader in reproductive medicine. It is my great pleasure and honor to introduce the first speaker. The first speaker is Professor Mohamed Abo Al Ghar. I think all of us know Professor Mohamed Abo Al Ghar. He is professor of obstetrics and gynecology. He is one of the pioneers of assisted reproductive technology in Egypt and in the Middle East, and he is well known for his enormous number of publications in this field. Professor Abo Al Ghar is going to address us on a very important topic, and that is mild stimulation. Professor Abo Al Ghar, the floor is yours. Thank you.
Mr. Chairman, ladies and gentlemen, I'd like to thank Dr. Yaqub for his kind invitation to me. It is a great pleasure to join any meeting he invites me for, and I'm very happy to participate in the meeting of Upper Egypt Society, which is a rather young society, but made a very big effort and very big achievements during the past few years. And I also thank Dr. Mohamed Fawzi, who is the local representative here in preparation of this meeting. The topic which was chosen for me by the program is mild ovarian stimulation. Really, there is no consensus on the definition of mild ovarian stimulation. Not everybody agrees on this definition. It may include modified natural cycle, the use of clomiphene citrate or letrozole, either alone or with the addition of a small amount or doses of FSH, the use of GnRH antagonist protocol with small doses of FSH or HMG. There is an international society for approaches in assisted reproduction, which is mainly dealing with the topic of mild ovarian stimulation, and they have their own definition. And this definition is mild or soft stimulation protocol is defined as administration of small doses of FSH or HMG for short duration in GnRH antagonist protocol, or when clomid or letrozole alone or with gonadotropins are used with the aim of collecting between 2 and 7 oocytes. So this is probably the definition we should follow. We have some problems with this definition, because if you consider 150 international units in an antagonist protocol is a soft protocol, then many cases which are stimulated by this protocol will produce more than 7 oocytes. Some of them even might develop ovarian hyperstimulation. So actually, we have to consider this protocol a mild ovarian stimulation. This is something which we should find another definition, or actually the borderline between what is called soft protocol and conventional protocol, they are really overlapping in certain areas. Unless we consider the clomid or small doses of HMG is the only mild ovarian stimulation protocol. There is a group of IVF specialists who believe in mild ovarian stimulation for certain reasons. For these reasons, it became popular in certain areas. They believe it is safer, and definitely it is safer for the patient. It's more friendly to the patient, and even they believe that it improves our IVF outcome, and it does not make a difference between the mild stimulation and the conventional stimulation. Nagund and Fowler rather recently, have written a review article on mild ovarian stimulation for IVF, and they said that this is the smartest way forwards in IVF, and this is the future of IVF. The mild ovarian stimulation protocol definitely has some values and some accomplishments. The most important is avoid complications and mainly ovarian hyperstimulation syndrome. And of course, it is less stressful. It is short protocols, minimum amount of drugs or injections. It's short treatment. The cost is lower. These are the main value of the mild stimulation protocols. And she suggested that the pregnancy rate or the live birth rate with mild stimulation protocol are comparable to those with conventional stimulation, in addition to the safety and the lower incidence of OHSS. Natural cycle IVF with or without modified cycle is definitely associated with fewer risks. No embryo selection, no cryopreservation. It is less expensive, but definitely it is associated with a lower pregnancy rate. On the other hand, many IVF specialists believe that the conventional stimulation protocol is the best protocol, and they have again their own reasons for this. Conventional protocol is accompanied by, we know it is accompanied by a higher risk of ovarian hyperstimulation. However, now there are several methods to reduce the incidence of OHSS if you are using the conventional protocol, particularly in high-risk patients, including choosing the antagonist protocol. You give a reduced dose of FSH or HMG. You trigger ovulation by a bolus of GnRHA. And if it is really a risk for ovarian hyperstimulation, you can cryopreserve all the embryos. It was recently demonstrated that the cumulative live birth rate following the transfer of all fresh and frozen embryos is significantly increased if you have a higher number of oocytes retrieved. You will have more embryos, you will have more transfers, you have a higher possibility of having a much higher cumulative live birth rate. In a meta-analysis, when comparing the pregnancy rate per fresh transfer, it was almost double. In this meta-analysis, the pregnancy rate per fresh transfer, the ongoing pregnancy rate per fresh transfer was 29% versus 15%, and the difference was clearly significant. So this meta-analysis showed that the mild ovarian hyperstimulation or mild ovarian stimulation syndrome results in a lower pregnancy rate. And again, what about cost effectiveness? Is it really cheaper? And this study showed that, in summary, 3 to 6 cycles of modified natural cycles with transfer of a single embryo is not really a cost-effective alternative. It's not cost-effective. Minimal stimulation in IVF versus conventional stimulation in a randomized study in over 500 patients, the cumulative live birth rate was 64% in conventional stimulation protocol versus 49% in the minimal stimulation protocol, and the difference was significant. The OHSS was more in the conventional stimulation protocol, and they transferred 2 embryos. So there was also a number of twin pregnancies in this study. The overall cost effectiveness of the baby in soft protocol will increase if you do repeated cycles to achieve pregnancy. But in reality, it is not really by the studies cost effective. Gruen evaluated the cost effectiveness of modified natural cycle versus conventional stimulation. The cumulative live birth rate in conventional protocols is higher than mild stimulation. After calculating for all factors, conventional stimulation will be more cost effective. So this study showed that it results in a better ongoing pregnancy rate and cumulative live birth rate, and also it is more cost effective. From 2004, Japan, which is a developed country, demonstrated the lowest fresh cycle birth rate in the world. And this decline coincided with the introduction of the Kato protocol, which is mild ovarian stimulation using Clomid and maybe small doses of HMG or FSH and single embryo transfer. And this is a clear example when you do for all patients this mild stimulation protocol, you will generally have a lower outcome for this country. So in conclusion, Mr. Chairman, the real value of soft protocol is controversial, and even the definition till this moment is not settled and could be debated also. And what are we going to do in the soft protocol varies from one place to another. What is meant by soft protocol is not clear. Sufficiently powered prospective studies applying novel mild stimulation regimens are really required. If we want to answer this question finally, we need a large prospective randomized study so we can get a proper answer, and we have to unify what is meant by mild stimulation protocol. The level of evidence supporting the use of mild stimulation is still rather low, and generally it is not recommended as a routine for all centers for all patients. Conventional stimulation protocol should be used carefully to avoid OHSS. We should use the minimum possible dose. In high-risk patients, we must use the antagonist protocol. We must be free in triggering ovulation with GnRHA, and if there is a real risk of OHSS, we should cryopreserve all embryos, particularly now the results of frozen thawed embryos are very good. And thank you very much.
Thank you very much, Professor Abo Al Ghar, for this excellent, precise presentation. And we shall move to the next presentation. Will Dr. Yaqub please introduce our next distinguished speaker? Thank you.